Guys, actually local complications list is a little more big, not as small as we thought. Look at this. There can be injury to nerve, blood vessels, visceral organs, muscle, tendon, joints, all that you will write. There can be non-union, delayed union, malunion, infection, compartment syndrome also is there. Okay, then there can be avascular necrosis, shortening of the limb can happen, joint stiffness, Sudex dystrophy. This is the sympathetic dystrophy, isn't it? They can have Sudex dystrophy. Then we talked about some other contracture, not just shortening of the leg. There is contracture, okay, and myositis ossificans. We have to look at what this is, and osteoarthritis we spoke of here. Pyogenic arthritis we spoke of. So did you understand that there are a few more words that we added just now? Compartment syndrome, avascular necrosis, shortening of the limb, joint stiffness, Sudex dystrophy, ischemic contracture, myositis ossificans, is it? Yeah, ossificans and osteoarthritis. Guys, osteoarthritis we have covered, so let's just remove this word. So did you understand? Joint stiffness, I think you will write anyways. Here you add just muscle, tendon and joint injuries. All this you can write, okay. So let's get started with injury to major vessels. So what happens here? These blood vessels will be in so close proximity with these bones, okay. So they are also liable to injury. Let us look at a table here which is showing you all the vessels which are injured in trauma. The femoral artery, right, because of your fracture to the lower third of femur. Look at this photo here. So here they are showing you that this is an arteriogram. There is injury to the femoral artery badly to a displaced fracture in the lower third of the shaft of femur. So lower third of shaft of femur, can you see the fracture? But I definitely can see a discontinuity here. Vascular injury in a fracture is an emergency. Hemorrhage, shock and compartment syndrome is common. So just because of vascular injury, there can be hemorrhage. Obviously, you know this, hypovolemic shock, etc. Compartment syndrome can happen because of the accumulation of these metabolites within the fascia. And they're saying that this has to be treated immediately. So you got a lot of information from this diagram, which is telling all the problems that can happen because of vessel injury. So hemorrhage, shock, ischemia, ischemic contracture, compartment syndrome, even gangrene because of this ischemia, isn't it? So there is something here called as exercise ischemia. Okay, what is this exercise ischemia? What is ischemic contracture? We need to look at a few terminologies here. Guys, focus here. What are we looking at? Vessel injury, right? So exercise ischemia. Basically here, the collaterals are good enough to keep the limb viable. Okay, it is enough to keep the limb viable. But further demand if you have, like during exercise, etc., then there will be ischemic pain. So you will have enough blood supply just to maintain the viability, but not to exercise, etc. That is ischemic exercise ischemia. Ischemic contracture, what is this? The collaterals, the collaterals, okay, the blood vessels, they do not supply adequate blood supply to the muscles. So what will happen? The muscles will have necrosis. There will be ischemic muscle necrosis. So this will lead to contracture and fibrosis. So what are they saying? There is ischemia, basically to what? The muscles. So there will be muscle necrosis. Okay, and that will follow with contracture and fibrosis of these necrotic muscles. These necrotic muscles will undergo contracture and what am I saying, guys, and what are you listening? Fibrosis, contracture, fibrosis will happen of the muscle. So this will lead to deformities. Example of these deformities are like Volkmann's ischemic contracture. Look at this, Volkmann's ischemic contracture, VIC. This is Volkmann's sign. So you can look at the contracture that is happening here, right? You can see the fingers contracted. Basically here, what is affecting? The muscles and nerves of the flexor compartment of the forearm. Okay, so there's occlusion of the brachial artery by a supracondylar fracture. What is affected here? The brachial artery. Okay, occlusion happens of the brachial artery. And here you are seeing that initially there will be severe pain and then he cannot move his fingers. You should understand this pathophysiology. Stretch pain, etc. will be there. So they are talking about some supracondylar fracture here. Vascular injury in a supracondylar fracture. So brachial artery becomes occluded. So just look at the other things here. We spoke about femoral artery, popliteal artery because of supracondylar fracture of the femur. Similarly, you have supracondylar fracture of the humerus where the brachial artery is affected. Then dislocation of the knee or the fracture of the tibia, you can have posterior tibial artery injury. Then you can have, if you injure your clavicle, guys, then subclavian artery you can injure. if you are going to dislocate your shoulder, you can have a axillary artery can get injured. Okay. So did you understand, guys? So let's look at this. So what and all did they tell you? Shoulder dislocation, axillary artery, then humerus brachial artery, femur, they spoke about femoral artery, then they spoke about the knee, right? For knee they said popliteal artery, etc. Then what else did you see? Popliteal artery, then tibia, dislocation of knee, they're talking about posterior tibial artery, subclavian, subclavicle, okay? All these arteries you will mention, correct? How exactly will you treat this injury to major vessels? Basically, they'll try to elevate the limbs, prevent the loss of blood, etc. They can even embolize these arteries, right? So that they don't bleed further. Vessels, they will embolize. Look at this treatment plan. You will touch and see, is there pulse? If there's no pulse, you will loosen the bandage. You will correct the gross displacement of the fracture under sedation. You have to sedate and try to correct the displacement. Then, you will correct any acute flexion. So if there's acute flexion in the nearby joints, obviously the vessel could have got compressed, so there's no pulse. Then you will wait for the pulse to return. If the pulse does not return, you will refer them to some specialized center they are seeing. Then what else are they talking about here? Here they are talking about splinting the fracture. You'll put a loose splint and observe, okay. Then here, if you're doubtful of the circulation, they will explore the vessel and they will check the vessel in continuity. If it is in continuity, they're talking about some if there is spasm, you will give xylocaine, papaverine, sympathectomy, etc. And if it is lacerated or a ruptured vessel, the vessel itself is lacerated or ruptured, then they have to repair it. Okay, you'll have to use some graft, etc. So that's it, guys. Almost 5 minutes we have spoken about injury to major vessels. Now let's go to this one, injury to nerves. Okay, injury to nerves. So obviously nerves are also in close proximity with the bone. So there can be nerve injury also. Very good. So the radial nerve is the most frequently damaged nerve in musculoskeletal injury. So which is the most common? Radial nerve. Radial nerve is the, let's use a yellow for the nerve. Wait. So radial nerve is the most common, so most frequently damaged nerve in musculoskeletal injuries. Okay. So what happens is nerve, see this is the bone next to it nerve, what am I saying? So if this is the bone, okay, this is the bone, next to it what and all will be there? Nerve will be there and vessel also will be there. Close proximity, both will be there. So it often happens that both of them will get damaged. So why does the nerve get damaged, guys? Because whatever caused the fracture, that itself can cause harm to the nerve, like a bullet or something, or pressure or some traction, right? Or some later when it's healing, there can be callus formation which can affect this. It can trap the nerve. Okay, so be very careful. So that is why you should always go to a doctor and get it, see if this is a bone and there's a fracture here, right? The nerve can get entrapped. So if they have not carefully checked, then when this bone is healing, there can be callus formation and the nerve can get entrapped. Okay, so all these are nerve injuries. Okay, you should know all that. And you remember Seddon's classification of nerve injuries. You have neuropraxia, axonotmesis, neurotmesis. All this you have to look in the Seddon's classification video. Here we are not there to discuss this. Here we are there to discuss complications of fractures. So you saw that all these same things, shoulder dislocation, axillary nerve will get affected. Humerus, if it is affected, then radial nerve, median nerve are affected. Ulnar nerve also can get affected because of humerus. Then if hip you have some problems, sciatic nerve you will injure. If knee you are hurting, you will injure the common peroneal nerve. It can lead to foot drop. Yeah. So all this also you can write. So what will be the consequences of hurting your radial nerve? Wrist drop. Consequence of hurting your common peroneal nerve, foot drop. And what about ulnar nerve hurting? You can lead to claw hand. All this you should know, right? Median nerve if you injure, pointing index. All this you have to write in the exam. They can just ask you claw hand as a question. They can ask you foot drop as a question. They can ask you wrist drop as a specific question in your exam, okay? How will you treat all these nerve injuries? Basically, you will check whether it's a closed fracture, open fracture, etc. Right? If it is a closed fracture, what can you do? So usually it will be a neuropraxia or axonotmesis. Anyways, it will recover, okay? So if you are doing some open reduction, you will have to explore the nerve, etc. If it is neuropraxia, what am I saying? Neuropraxia and axonotmesis, no issue. But if it is neurotmesis, you will have to repair the nerve, right? Great. Now we are done with nerve. Now let's move on to muscle and tendon. Okay. So some degree of muscle and tendon damage will be there, right? What else? Just give rest to that person and analgesics. That is enough if there is partial rupture. If this complete rupture of this muscle tendon, you will have to repair it, guys. Okay. You will have to reconstruct, etc. Now let's go to injury to joints. We have finished nerve injury, vessel injury, muscle injury. Now let us go to joints injury. Let us say the joint itself got dislocated. A subluxation has happened. What will you do? Yes, open reduction you will have to do, and you have to stabilize the fracture to permit early joint movements. Okay. Is that becoming too much, guys? What are we looking at? We are looking at local, say, complications of fracture we are looking at. Better color, please. We are looking at complications of fracture. In the local complications we are looking at. In local complications, we are looking at the immediate complications. Immediate complications, what we say? Injury to vessels, injury to nerves, injury to muscle, injury to joints. Lastly, we are looking at injury to viscera. Viscera can be in any visceral organs or the viscera itself. So we are done with injury to viscera. Viscera injuries is covered separately. That's what the textbook says. Now let us move on to early complications. Okay. So early complications, local, they are talking about infection and compartment syndrome. Let us look at this. Infection, what are they talking about infection, guys? Zoom this. Infections, osteomyelitis, right? Basically, if it is an open fracture especially, there will be infection, right? So that can lead to osteomyelitis, that can lead to gas gangrene, right? All that you have to write here. It can lead to, especially in open fracture, what can happen? It will lead to infection, which will lead to osteomyelitis and gas gangrene. Gas gangrene will be because of Clostridium perfringens, isn't it? Gangrene. R-E-N-E. Okay. Then how will you prevent infection? Obviously, you will have to give disinfection, etc. Now let's go to compartment syndrome. You'll have to give a tetanus shot to these people in case they fall, right? You want to prevent tetanus, Clostridium tetani. Shall we move on to compartment syndrome, guys? See, basically, if you're looking at your limb, right, what is there outside? You have skin. Inside that you have fascia. Inside fascia you have muscles, right? Like this is the flexor compartment. Then you have the bone and there is some intraosseous membrane. And then you have some other compartment, right, which has the muscles. So basically, these are the compartments. Like this could be we are not sure here, but this could be an anterior compartment. This could be a posterior compartment, right? So basically, this compartment, if there is a problem, it's called as compartment syndrome. Anterior compartment, posterior compartment, compartment. You understood the word, right? So there is increased pressure inside these compartments. So what is there in these compartments? Increased pressure. So the patient will have pain. Okay. When you do a stretch test on these people, right, what will you see? Basically, let us say, if you extend the fingers, there will be pain in the flexor compartment. So that will tell you this is an earliest indication of compartment syndrome. So these people will have a tense compartment, hypoanesthesia in the distribution of these involved nerves, muscle weakness, etc. Okay. So why does all this happen? To explain that there is this Eaton and Green cycle, you can see this. Basically, whenever there's trauma, what happens? There's ischemia. There is less blood supply, right? What happens when there is less blood supply to this compartment? There is histamine release. There is increased capillary permeability. So what happens when there's permeability is more of the capillary? Everything from the capillary will come out and there will be edema. So you can understand why it is swollen, tight, because there is edema. This edema will increase the pressure. Now this will, there will also be this lymphatic drainage. At least the lymphatic drainage should help resolve this edema. Even that gets blocked, okay. So there is, from the capillary something is coming out and the lymph is not able to drain. So everything accumulates here, right? So there's edema. Increased pressure. This will further lead to arterial occlusion, spasm, nerve damage. So this is more like a cycle. You understand, right? That will further lead to ischemia, again edema. Edema will lead to ischemia, ischemia will lead to edema, like that. Okay, this is the eat on green cycle. Okay. So did you understand? So you should talk about pressure, guys. What is the pressure in compartment syndrome? It is greater than 40. Pressure is greater than 40 millimeter of water. Okay, so this will indicate that there is compartment syndrome. Okay, pulse may be palpable, guys. That is saying, so don't This will be like, don't get confused with that. Pulse may be there, but you should be very careful about the increase in pressure. Now, how will you treat this? Early, you can just do limb elevation, finger movement, etc. you can do. Otherwise, what you'll have to do, you'll have to do surgical decompression. I think they will do a fasciotomy. So, fascia is here, you will do a fasciotomy, isn't it? So, they will split it longitudinally. So, let us say this is the limb of that person. They will split the fascia longitudinally, fasciotomy, okay? Deep fascia of the compartment is split longitudinally. There is something also called as fibulectomy. The middle third of the fibula is excised. So, they are talking about lower leg and leg. What happens? You have the fibula laterally, right? The middle third of the fibula is excised in order to decompress all compartments of the leg. They are talking about removing middle third of the fibula, fibulectomy. Okay. Guys, you are done with the local complications, infection and compartment syndrome. Now, let us move on to the late complications. Late complications of fracture, that is local ones we are looking at. All these are local, so there are so many more to look at. You have to look at delayed union, non-union, malunion, cross-union. You have to look at avascular necrosis, shortening, joint stiffness, Sudeck's dystrophy, ischemic contracture, myositis ossificans. All this you have to look at still. Guys, now let us move on to the late complications of fractures, the local ones. Everything is local only. Late, they are not expecting any systemic complications. Look at this late complications. Basically, there can be imperfect union of the fracture, that is delayed union. It's taking a long time to unite. And finally, it may not unite. It may be a non-union. It is not uniting at all. There could be a malunion. It is not united properly, or there could be a cross-union. There are so many terminologies here. Actually, a non-union can be because of a pseudo-union. That is, it is not united correctly. Pseudo-union. Pseudo-joint forms. Okay, pseudo-joint. That will be called as pseudo-arthrosis. So, all this can happen. So, you are waiting for the fracture to unite, but it is not. So, you don't know whether it is a delayed or a non-union. Usually, it's after 6 months, they will say it's non-union. Guys, are you focusing? Where are we? What are we looking at today? Complications of fractures, late complications. In that local ones only we are looking at. Basically, union, they are saying delayed union, non-union. There can be pseudo-joint that is formed. There could be pseudo-arthrosis. Basically, if there is non-union, how will you know? There will be mobility at the fracture. At the fracture, there will be presence of mobility, or there can be pain. But if a pseudo-joint has formed, there may not be pain also. Okay. So, there are a lot of causes for this happening. Anyways, look at this photo. There are types of non-union. There is atrophic non-union and hypertrophic non-union. What is atrophy, guys? According to pathology, you have heard, right? Basically, there is reduction. So, here what you can see is atrophic. They are saying that there is minimal or no attempt at callus formation. It didn't even bother to fix it, kind of a thing. Minimal or no attempt to make callus at all. And in hypertrophic, what happens? It is made a lot of callus, looks like, right? But still, it is a non-union. So, this callus is present, but it does not bridge the fracture, okay? So, basically, why do you think all this happens? Why is there a delayed union, etc.? That is because of age, right? Or there could be an associated malignancy, or these people can be having, there is some problem at these fracture sites, like patella fracture and all. There will be muscles which are pulling these fragments, okay? The gravity may not help the union, right? Like shaft of humerus, if it is affected, then the gravity will play a factor. Then what else, guys? What do you think? Why do you think there is no union of these fractures? Bone loss, infection, damage to the blood supply. Very good, very good. And then there is you didn't reduce it properly. You didn't, you have to do some close reduction and all that, or open reduction. You didn't reduce the fracture properly. So there is delayed union or non-union, right? Then you did not immobilize the patient properly. After his fracture, you have to cast and immobilize, right? You'll have to put splint, etc. But maybe that immobilization was not done. This guy was happily using his limb the whole time, and it became a malunion. Sorry, I mean a delayed union or a non-union, right? Then, what else? Now let's move on, guys. What will be the consequences of this non-union? Can you think about a consequence of a non-union? Pain, deformity, abnormal mobility. Yes, very good. So, if he has again stress, it will break again, kind of a thing. Especially look at this. It can break again, isn't it? Then what are we looking at? Yeah, we are looking at the treatment of this malunion. So, basically what you'll do, again, you will do open reduction. right? You'll have to open it and reduce it this time, not a closed, but you're talking about an open reduction. You'll have to internally fix it. You'll have to do some bone graft, right? You'll have to do some internal fixation, they're saying, or you'll have to do some bone graft. Then you'll have to remove some fragments. If some extra fragments are there, you'll have to remove them, excise those fragments. What else, guys? There is something called here as Elizarov's method. What is that? So they are trying to treat this non-union by external fixation, guys. That is only this Elizarov's method. Look at this. Elizarov's method, external fixation. Okay, they are trying for the thigh and leg, actually here they have shown. Basically for what? What are they trying to treat, guys? Non-union. Okay. In non-union, there are some strange words. Okay, look at this. Elephant foot, types of non-union. Hypervascular type, avascular type. So under hypervascular you have elephant foot, horse hoof, oligotrophic. And in avascular they are talking about torsion wedge, comminuted, see so many pieces. Defective and atrophic. Same, they have shown some photos also how to fix it, kind of a thing, right? Are they showing how to fix it? Yes, in an attempt to salvage the limb. So all these are non-unions. Non-union done. Next is what? Malunion. Very good. So malunion is where you have, see, some degree of malunion will be there in most of the fractures. Okay, you will not have a perfect union. So now let us say this is the bone and this is the bone and these two had to unite. So perfection won't be there. Some degree of malunion will be there. Okay, that is okay, acceptable, but it should not be so severe that it will lead to deformity, right? So that is what they are talking about here, malunion. Why will malunion happen at all in the first place? Because you gave improper treatment. So that is why this is a preventable complication, isn't it? So you should be very careful while treating the fracture. So you will unite it, but make sure there is no malunion. Especially in fracture of clavicle, in Cole's fracture, etc. Because of lot of fragments, there can be malunion. Clavicle, because there can be a muscle pull, right? Some muscle pull, unchecked muscle pull. That's what this says. So because of all this, there can be malunion. What are we talking about? Malunion. Look at this. They are talking about the intratrochanteric fracture comminuted. So there's malunion here. They are saying here this is Cole's fracture, deformity because of malunion. Okay. So how will you treat malunion, guys? The strangest thing is for malunion, the corrective treatments are very strange names. Okay. I will just write them here. How will you treat malunion? The words they are using are osteoclasis is refracturing the bone. Because it's malunited, they are refracturing it, is it? Wow. Okay, I'll just tell you the names, okay? Then, redoing the fracture surgically. It's a commonly performed operation for malunion. Which one? Redoing the fracture surgically. Okay, then corrective osteotomy. Are these terminologies making any sense to you? Let's read, okay. See, in the first one, what they're saying, refracture the bone, this is exactly what they're saying. You give general anesthesia, you recreate the fracture, you correct the angulation and immobilize the limb in plaster. Now, what is this redoing the fracture surgically? So basically in this redoing the fracture surgically, you're just treating it again. You're exposing the fracture site. You will correct the malunion and then you will fix the fracture internally with suitable implants. So you're kind of correcting the malunion. You're fixing it internally, the fracture again. Okay. Then bone graft, etc. you can do. Bone graft is also performed. Okay. Especially for long bones. Otherwise what will happen? There will be shortening of limb and all, is it? Then corrective osteotomy. What is this osteotomy? What do you think it is? See, what they are telling here is you may not be able to redo something in the same place because of some cosmetic reasons. So what they are doing is they will at a site away from the fracture, guys, focus here. Away from the fracture itself, they are doing something. Osteotomy. Example, in distal third tibial fractures. Where's the tibia here? So I'm just marking the leg here. So tibial fracture, that is the distal third tibial fracture. The supramalleolar corrective osteotomy doing that. Fixing something here. Supramalleolar corrective osteotomy for malunion of the distal third tibial fractures. Strange, right? So the deformity is corrected by osteotomy at a site away from the fracture. That is corrective osteotomy. There's one more term here, guys, called as excision of the protruding bone. Excision of the protruding bone. Okay. That also you can do. I'm just guessing if there is something there that is protruding, they're going to shave it off or something, that bone spike. Before doing all this, they actually try to remodel. This remodeling works if the person is young or if there is some sideways shift, some 5 to 10 degrees they can correct, some angulation in the plane. These are some factors that will help. And location of the fracture. If the fracture is near the joint, then it will remodel better. Okay. Then, what is cross union? Let's cover this cross union. It's a special type of malunion itself. Then let's put it here. It's a special type of malunion. Cross union is a special type of malunion which occurs in fractures in the forearm bones. Only the forearm they are talking about. So, two bones unite with each other. Especially where this is a special type of malunion. You can see in forearm, two bones unite with each other. Let's see what bones. I'm guessing it is, yeah, you guessed it right, guys, like the radius and ulna. Obviously in forearm, what else is there? Radius, ulna. In radius ulna fractures, what will happen? They are joined together by this callus. Okay, so it is a cross union. So, if this is the radius and this is the ulna and they have fracture at the same site, the callus will form in such a way that it will unite these two bones. So, that time what will happen, there's a cross union and the person's limitation, there is complete limitation of the forearm rotations. So, did you understand cross union, guys? It's a special type of malunion. Still, we have to look at these many things, guys, like avascular necrosis, shortening, Sudeck's dystrophy, myositis, ossificans, so many things are there. Just come back in the next video, we will look, okay, because this is such a huge chapter.